All right, I'm excited to welcome everybody to this week's Medicine Grand Rounds. Very excited to have two superstars in their fields here today, Dr. Matthay and Dr. Calfee, and I'll introduce them individually and then let them take it away. So Dr. Calfee is a professor of medicine and anesthesia in the Division of Pulmonary, Critical Care, Allergy and Sleep Medicine at UCSF Health, former chief resident at UCSF, joined faculty in 2007, did her crit care fellowship here at UCSF, and got a master's in clinical research as well in 2009. And her research focuses on the biology and treatment of ARDS and sepsis as it relates to molecular phenotyping, tobacco exposure in lung injury, and precision medicine as well. Dr. Matthay is a professor as well of medicine and anesthesia in the same division at UCSF Health. He's the associate director of critical care medicine here at UCSF Health and did his pulmonology fellowship here as well. His research focuses on improving the clinical care of people who have ARDS and people who have sepsis. And in 2013, he received the UCSF Lifetime Achievement in Mentoring Award. And in 2014, the American Thoracic Society's Trudeau Medal for lifelong contributions to research, teaching, and patient care. So very excited for this grand rounds today. Thank you.
Thank you, Allison, very much. I'm going to start off and then Carolyn will take over about halfway through. And we appreciate so many of our team that are here and would like to emphasize that everything really that we're presenting represents a team effort from so many individuals. And we just want to acknowledge that. I think you'll see that in some of the slides. So our title is ARDS, Current Therapies, the New Global Definition, and Implementing Precision Critical Care. These are my disclosures. There are no conflicts of interest for this presentation. And here are Carolyn's disclosures, no conflicts for this presentation. Here are 4 learning objectives. First, identify the current evidence-based practice for ARDS patients. Second, review the new global definition of ARDS. Third, summarize progress to date on identifying molecular phenotypes of ARDS and understanding their biology. And finally, identify future directions in critical illness phenotyping and how these may impact clinical trials. I'll start with a case report. This was a 40-year-old previously healthy gentleman with 4 days of URI symptoms, increase in shortness of breath over the last day, a mild productive cough, and he presented with a temperature of 39.5, heart rate of 130, blood pressure 120/50, and he was quite tachypnic with a respiratory rate of 30. He had a marked increased work of breathing, diffuse rales, initial oxygen saturation was 78% on room air, and then it increased only to 88% with 6 liters of nasal oxygen. His course in the emergency department was characterized by transition pretty rapidly to high flow nasal oxygen at 30 liters per minute. He was given a Zithro, ceftriaxone, and Tamiflu, IV fluids with plasma and admitted to the ICU. In the ICU, he developed much more hypoxemia and shock. Arterial line and CVP were inserted. His blood pressure was down to 80/40, so Levophed was started to treat his shock. Oxygen saturations declined even on high flow nasal oxygen, 30 liters per minute, so he was intubated and positive pressure ventilation was initiated. Now, what are the evidence-based principles of therapy for this patient with ARDS? I'm going to review 4 major clinical trials that I think guide us today and really are the foundation of our therapies. So the major breakthrough for which we're always eternally indebted is the NIH, National Heart, Lung, and Blood Institute, established a clinical trials network in 1994. They had previously established one in asthma, but this was a really major breakthrough because all the prior funding went to basic lab research. And this ARDSNet 1 and 2, and then what followed it, PEDAL, Prevention and Treatment of Acute Lung Injury, was funded for 30 years. through 2023, and you can see there were about 20 sites around the country. Initially, there were just 10 sites. Now, it resulted in clinical trials that improved clinical practice, and 2 were based, as I will show you, on laboratory preclinical research, both of which were done here at UCSF. In addition, the networks provided biology samples that have helped to transform our understanding of ARDS and sepsis and pneumonia through a large number of secondary analyses, some of which I will show you and Carolyn will show you. Now, where were we in 1994 when the NHLBI ARDS network was established? Well, in terms of ventilator management in the ICU, hypoxemia had been the focus of clinical management. High levels of PEEP and high tidal volumes were designed to reduce the FiO2. The major concern was oxygen toxicity. So the idea was, by the time you presented the case to your attending the next morning, you were supposed to have been able to lower the FiO2, and that was accomplished by high PEEP and high tidal volumes. A survey study in '92 showed that most intensivists were using tidal volumes much higher than 10 mLs per kilogram. And there was no clinical evidence that the way we ventilated patients with high airway pressure and high tidal volumes was making the lung injury worse. However, there was preclinical research that indicated high airway pressures were injurious and PEEP was protective in animal studies. In fact, the first study was done here in the CVRI at UCSF by Webb and Tierney in '74. You can see the figure from that study here, and the lung on the far right, as you're looking, is injured, edematous, and consolidated, and those were rat lungs that were ventilated with a high airway pressure of 45 centimeters of water. When the investigators added 10 of PEEP in the middle panel, you can see the injury was much less. So 2 things happened. PEEP was added, but also the net transpulmonary pressure went down from 45 to 35. And then at 14 centimeters of water, there's no injury. Now, interestingly, then Parker at Alabama and dog studies in the '80s followed up and did excellent studies to further support this hypothesis that high airway pressures were injurious. And then Dreyfus and his group in Paris in the '90s followed up with further studies in rats. So we met as a group, and actually 6 different times in '94 to '95. And there were 2 prevailing options for designing a clinical trial for ARDS. One was to test a lung protective strategy, or second, to test a systemic treatment to reduce inflammation from sepsis and pneumonia. Now, many patients died with multiple organ failure, so how could a lung-directed treatment work? So we were quite at odds and didn't know what to do, but our PhD statistician suggested, stop arguing, you can do a factorial design, and you can test both ideas. So we did KARMA, ketoconazole, which may seem pretty odd, but it was an anti-inflammatory at the time, and that was then paired up with lung protective ventilation. Then the issue was, should the target be low tidal volume or a plateau airway pressure limit? Luckily, we were able to consult with John Clements, who really was the person who achieved the breakthrough work that discovered and helped to implement with Mary Ellen Avery in Boston, surfactant for infant respiratory distress syndrome. So John said, oh, Michael, there's no question, use both, because you're talking about injured alveoli. You want to minimize the injuries, so you should make both part of the protocol. And then the network was not funded to do biology or obtain plasma samples. It was supposed to be devoted to trials, but several of us argued for obtaining plasma samples, and then it was finally agreed that we could do that for some biology measurements. So here's the results of the trial, published actually 25 years ago in the New England Journal in 2000. This was the seminal trial of 861 patients that demonstrated mortality benefit of a low tidal volume, 6 ml per kilogram, and plateau airway pressure limited strategy, less than 30 centimeters of airway pressure. It changed the standard of clinical care for ARDS patients, and it still is the standard 25 years later. Imagine if we hadn't had this, for example, during the pandemic. How many lives were probably saved because of this? Remember, during the pandemic, the incidence of ARDS increased tenfold. Now, there were challenges to achieve broad-based implementation. There were some arguments among our colleagues in critical care medicine. Some wanted to just use tidal volume, 6 ml. Some wanted to just use the plateau airway pressure. But I think we've now succeeded to have much better implementation around the world. But note that it took 26 years to translate from the first preclinical research study. Now, the plasma biology studies made it possible to understand the mechanisms of benefit from the lung protective ventilation strategy. You can see the difference in mortality, almost 10% here between the 6 and 12 ml per kilogram group. And what we found is that in the plasma samples obtained 3 days after the institution of either strategy, that there were reduced plasma levels of IL-6, IL-8, TNFR1, SPD, and RAGE, the last two being markers of alveolar epithelial injury. And so this gave us a really good mechanisms for understanding how the low tidal volume worked. This slide is just a depiction and a figure. On the far left, as you're looking, is the injured alveolus with the pulmonary edema, fluid meniscus, injured endothelium, epithelium, inflammatory cells, macrophage, neutrophils, and pro-inflammatory factors. And then in the upper panel, you can see the injurious effect of high stretch ventilation. The edema fluid is worse. There's endothelial and epithelial injury and more inflammatory factors. This was demonstrated in experimental studies that we did and others, as well as the clinical data. And then in contrast, low stretch results in a reduction in pulmonary edema, less inflammation, and less barrier injury. So now the next major trial was set up because of just outstanding physiology-based work done here by Norman Staub, who was really I think the real father of modern pulmonary edema research and understanding how to distinguish cardiogenic high pressure from permeability edema. Now, this slide shows that increased lung vascular pressure markedly enhanced pulmonary edema formation in the presence of increased lung permeability in sheep. The x-axis shows lung edema formation, the y-axis shows lung edema formation, and the x-axis shows pulmonary hydrostatic pressure. Just think of it as left atrial pressure. So under normal conditions, as left atrial pressure rises, the amount of edema that forms is gradually increased, as shown in the lower line. But in the presence of increased permeability with pneumonia, aspiration, sepsis, the lung is already accumulating edema fluid. And if you raise vascular pressure just by a small amount, you can see how much more edema is formed. So that was really the principle of Norman's study, and that was published in Chest in 1976. So then here we fast forward years later to the FACT trial, and this was the factorial design again, as we had done in the KARMA trial. And the comparison here was the PA versus CVP catheters and fluid conservative versus fluid liberal management in ARDS. There was a lot of equipoise for these two options. The liberal fluid was thought to be necessary to maintain organ perfusion, kidney function. The conservative approach, of course, it was thought, reduce the degree of edema, but it really wasn't known. So it turned out that the fluid conservative strategy reduced the duration of ventilator support, and there were no harmful effects on kidney function, something that Kathleen Liu here studied extensively as part of this study. It opened the door for fluid conservative strategies in other areas of critical care medicine, including after major trauma. Also, the minimal value of PA lines in this setting changed clinical practice in the ICU to just using CVP lines, and really, I think, paved the way to the expanded use of bedside ultrasound. And so it took 30 years, but this ultimately preclinical research was translated. Now, the next third trial I wanted to discuss is the PROSEVA trial, published in the New England Journal in 2013. This was the PRONE trial, which showed increased survival in ARDS in patients with moderate to severe hypoxemia, a PF less than 150. This is an example of what we call prognostic enrichment. So you're picking the patients who might benefit the most from this approach. In fact, there had been an earlier trial in Europe using the prone approach with patients with ARDS with a PF less than 300, and it was not effective, but a post hoc analysis showed that it looked like the patients with more severe hypoxemia might have benefited. So this new trial was organized and run by the French, and you can see the big increase in survival in the patients in the prone group. Now, how did this actually come about? Well, Luciano Gattinoni, the late professor from Milan, he had made remarkable observations published in Anesthesiology and JAMA in 1993 with his CT scans, in which you can see that the consolidations in the patients with ARDS in the supine position are in the dependent areas. But when the patients return to the prone position, look how the consolidation shifted, and now you have aerated areas in the dorsal regions. And they found in this case study that the oxygenation markedly improved. And this concept of prone being beneficial was also supported by experimental studies from Rick Albert in Colorado and others. So it's a good story. Dr. Gattinoni passed away last year, but this is a lasting impact. And again, this is a method that was used and still is used, of course, in our ICUs and was a big benefit during the pandemic. Now, there's one other new development that I thought I would mention about prone positioning. There's an excellent report I recommend to all of you to read in JAMA Internal Medicine, published last spring. And this was a meta-analysis of 14 randomized trials in 3,000 patients. They all had COVID-19 respiratory failure, and they were randomized to awake prone positioning or just supine. And turned out the prone positions patients had a big improvement in survival without intubation, reduced risk of intubation, and a reduced hospital mortality, a very big effect. And so several of us wrote a commentary about this very excellent report that we entitled, "Is There a New Standard of Care for Acute Hypoxemic Respiratory Failure in Spontaneously Breathing Patients?" I think this probably would work today. The problem is, could we actually even do a trial like this and have equipoise? It might be hard, but I think that this is just another prone positioning has benefited our field. And the final trial is, again, a terrific French trial published in the New England Journal in 2015. This is the high flow oxygen through nasal cannula for acute hypoxemic respiratory failure. This changed clinical practice before, during, and after the COVID pandemic. And just for a brief reminder, there were 310 patients. They were identified in the emergency department. They had to have a respiratory rate greater than 25, PF less than 300. They could not have hypercapnia, so they weren't confused with COPD with hypercapnic respiratory failure, and no chronic respiratory failure. Pneumonia was the most common cause. Well, it turned out, even though it's a small study, relatively multi-center, that those patients given high flow nasal oxygen had a marked increase in survival compared to those treated with standard oxygen or non-invasive positive pressure ventilation. And also the patients who had more severe hypoxemia had a reduced rate of intubation. So this is a landmark trial that's changed our field everywhere, in the OR, the ED, the ICUs, and so on. Now, our second learning objective was to review the new global definition of ARDS. So just by way of reminder, most everyone knows that it was Dr. Petty and his colleagues that actually described ARDS in 1967 in this ARDS, in this Lancet publication. So actually only 12 patients, they all had bilateral chest radiograph infiltrates consistent with pulmonary edema, hypoxemia and stiff lungs, not primarily due to heart failure, and the risk factor was pneumonia, severe infection, severe trauma, and included children. Well, over the years, there's been different modifications and efforts to define ARDS. The most recent one, before the new one I'm going to tell you about, was the Berlin definition of ARDS, published in JAMA in 2012. Carolyn and I think this really isn't much different if you think about it from the original definition. There were a couple advances. It emphasized now in this new era to use echocardiogram to try to rule out LV dysfunction as the major cause of the pulmonary edema and respiratory failure. All the patients, though, needed to be intubated, except for a small subgroup with mild respiratory failure who could be treated with CPAP. But for the most part, all these patients with a Berlin definition were intubated. Now, the problem is, as we all learned during COVID, but even before then, there were patients like this who had bilateral infiltrates, severe edema on the X-ray. In this particular case, the patient is being supported with high flow nasal oxygen, 30 liters per minute, FiO2 of 0.7. The arterial oxygen tension is 79. The PF ratio is low at 112. Does this patient have ARDS by the Berlin definition? And the answer is no. So that seems a little bit off. So several of us thought that we needed to think this through. And this slide just summarizes what changed since the 2012 Berlin definition. One, markedly increased use of high flow for acute hypoxemic respiratory failure. Two, recognition that the SF ratio, the oxygen saturation divided by the fraction of inspired oxygen, might be a reliable surrogate for the PaO2, FiO2. So maybe the patient doesn't need a blood gas. And then importantly, recognition of limitations of the Berlin definition for resource-limited areas of the world where chest radiographs and blood gases were not, or frequently, most of the time, not available. So we organized a consensus conference group with considerable diversity, international. You can see several members of the group listed that you can see them here, Carolyn and Kathleen, Brian Daniel, and Jeff Gotts, but we had a very broad group here. It couldn't have too big a group or it becomes unwieldy, but we met 6 different times by Zoom, taking advantage of the pandemic use of Zoom, and lots of subcommittees. And at what we wanted to do was to address several issues that had arisen since Berlin definition. Should intubation or non-invasive ventilation be required for diagnosis of ARDS? What about high flow? And what about resource-limited settings? Is the SpO2 FiO2 ratio an adequate substitute for the PF ratio for assessing hypoxemia? Beth Riviello at Beth Israel in Boston had proposed a Kigali definition a few years before to modify the Berlin definition to make it applicable for under-resourced areas in the world. And should we have bilateral versus unilateral opacities? The pediatricians had abandoned bilateral and changed their definition to include just unilateral. And can ultrasound be used for chest imaging? Well, just to summarize the final recommendations here, they were to retain the conceptual model from the Berlin definition, that ARDS is a type of inflammatory lung injury with increased permeability across the endothelium and the epithelium. And we decided to retain the requirement for bilateral radiographic opacities, but we wanted to expand the Berlin definition to include non-intubated ARDS with either non-invasive or high flow with a minimum of 30 liters per minute. Add the SpO2 FiO2 ratio as an alternative to the PF ratio for the oxygenation criteria, and allow the use of ultrasound with a well-trained operator to diagnose bilateral opacities, primarily in resource-limited settings. And then importantly, we applied the Kigali definition for ARDS in resource-limited settings, including the SF ratio, and not required a minimum flow rate of oxygen or end-expiratory airway pressure. So this slide just gives you 3 examples that would be covered by the global definition of ARDS. The top one is a 68-year-old gentleman with abdominal sepsis, septic shock, and acute hypoxemic respiratory failure. He's intubated, as indicated by the yellow arrow, and he has a PF of 150, so he fits the classic Berlin definition. The second one is a 50-year-old woman with a history of breast cancer, COVID-19 pneumonia, and worsening dyspnea for the past 6 days. She has bilateral infiltrates, but she's not intubated, and she's being treated with high flow nasal oxygen and is quite sick, 40 liters per minute with an SF of 114. So she would qualify with the new global definition. Finally, is a 39-year-old woman with abdominal sepsis and gram-negative bacteremia in a small under-resourced hospital. in sub-Saharan Africa without blood gases, radiography or mechanical ventilation. Ultrasound shows with B lines that she has bilateral opacities, and she has an SF ratio of 142. So that brings us up to this slide, which is that even with the new ARDS definition, challenges remain. So now I'll turn it over to Carolyn.
Thanks so much, Michael, for that wonderful review and overview of the many advances that have been possible with the syndromic definition of ARDS that we've been using for all of these years. But as Michael said, even with this new definition, we have many challenges. ARDS is by definition a syndrome. It's not a specific disease. And actually, when we look at pathology of patients who were diagnosed with ARDS on autopsy, we see a wide variety of pathological findings, including in some patients' normal lung. We have no sensitive or specific diagnostic test for this, right? It's a constellation of findings. And we know that we're not capturing with that syndromic definition the key features of the pathology that we're trying to model in animals, which again is that increased permeability of the endothelial epithelial barrier in the lung. We also know there's considerable clinical and biological heterogeneity in our patients, as you've seen from the case examples that have been presented. Critical illness has this as a problem in general, right? We define our patients using syndromic terms like ARDS on the right, or sepsis, which is also a syndrome, right, of life-threatening organ dysfunction caused by a dysregulated host response to infection. We think of these as discrete syndromes, but of course, many of our patients are somewhere in the middle, right? They meet both criteria, or they're close to meeting both criteria. And it's possible that some of this syndromic nature and heterogeneity is part of the reason that we have had decades of failed clinical trials in this space. So these are just some of the therapies that have appeared to cure mouse ARDS in many, many instances, including ketoconazole, which you see up there, and have failed, unfortunately, to translate into effective therapies for patients. We can talk about corticosteroids if you want, it's got an asterisk. But maybe part of the problem is that heterogeneity, and that really gets back to the sort of classic lumping versus splitting debate in medicine, right? When should we be lumping our patients together? When should we be splitting them out more? But maybe we need to be doing a little bit more splitting in ARDS if we're going to find these effective therapies. Now, other fields of medicine have had quite a bit of success in this. We can call it splitting, we can call it precision medicine, which sounds nice, right, for grants. We're talking in this case about treating patients based on their biologic phenotype, right? We do this in other fields of medicine quite a bit. Think about breast cancer, right? Hormone receptor positive or hormone receptor negative. We think about treating those patients differently. We think about receptor status in melanoma or many other malignancies, Th2 high versus Th2 low asthma. And so we thought, well, maybe an approach like this could help us in critical care. And so we started asking this question in ARDS. So now I'm going to transition to our next learning objective, which is summarizing progress to date on identifying molecular phenotypes of ARDS and sepsis and understanding their biology. Now, like any approach to splitting, there are lots of different ways to slice the pizza here, and people have been thinking about this actually even since that initial 12-patient case report. In the Lancet, they've been thinking about, there are actually some differences within the syndrome, and maybe we should be splitting patients in different ways. Severity, pulmonary versus non-pulmonary source, focal versus non-focal chest radiographic findings, all sorts of different biologic approaches, right? But they may or may not identify groups that respond differently to treatment, which is, I think, really what we're looking for when we're trying to design new therapies. So we've been taking a data-driven approach to this using an analytic approach called latent class analysis. And I'm just going to go through this briefly, so don't worry, we're not going too deep into stats here. But the idea here is using a set of criteria called mixture models to determine whether there's evidence that there are distinct subgroups within a more heterogeneous group of patients. So if you see this figure on the right-hand side and the black line is the observed distribution of data, you ask, well, does that better fit with the hypothesis that this is one homogeneous group of patients, or actually that there are two groups of patients, as you can see in the blue and the red underneath it? And with modern computers, you can ask this question of dozens of different variables at the same time and actually test the hypothesis about which model is a better fit for that data. So this can be totally independent clinical outcomes. And that's how we used it in ARDS. We said, okay, let's just take the features of the patients when they come into the ICU with their ARDS, their clinical features and their biological features, and see, can we find evidence that there are distinct subsets within there? And what we found over and over again is that latent class analysis consistently identifies two distinct phenotypes in ARDS. These are characterized largely by differences in inflammatory biomarkers in their plasma, and we've termed them therefore hyper and hypoinflammatory, and I'll show you more about that on the next slide. They have widely divergent clinical outcomes, mortality, even though we did not use anything about their clinical outcomes when we were modeling, right? We just modeled it based on all those baseline features as if we were blinded to what was going to happen to the patients. We've replicated this finding now in over 12,000 patients, in adult and pediatric patients, in randomized controlled trial data, and in cohorts. And importantly, these two groups do seem, in fact, to respond differently to therapies, and I'll show you some of that moving forward. This slide just covers the continuous variables that were used to identify the phenotypes in the latent class analysis, and those are spread along the x-axis here in order from maximum positive difference on the left-hand side of your screen to maximum negative difference on the right-hand side of your screen. I don't expect you to read all of these, but just to note that the features that are higher in this hyperinflammatory phenotype, which consistently is about a third of patients, are inflammatory biomarkers in the plasma. So interleukin 6 and 8, TNF receptor 1, Pi1. And this group also has lower levels of bicarbonate, so the patients are more acidotic, lower protein C, they're more coagulopathic, and lower systolic blood pressure. Some interesting features were in the middle. White blood cell count, age really did not discriminate the two phenotypes. It's those variables at the extremes of the figure that distinguish the two. Now, ARDS risk factors are important and are associated with each of the phenotypes. So, and I'm sorry that the legend got cut off here, but the hypoinflammatory phenotype is in blue and the hyper is in red. And you can see that there are some differences. So patients with non-pulmonary sepsis were more likely to be hyperinflammatory, and patients with trauma were less likely to be hyperinflammatory. But overall, this was not just one group is sepsis and one group is pneumonia. All right, now I mentioned that we did not include clinical outcomes in the modeling strategy. So let me show you some clinical outcomes from a variety of studies ranging from the mid-1990s, that original ARMA low tidal volume trial that Dr. Matthay told you about that changed practice, right, by showing that lung protective ventilation was really critical. You can see that mortality from that time up until the ROSE clinical trial of neuromuscular blockade, published using patients from the mid-2010s, consistently mortality in that hyperinflammatory phenotype is much, much higher than in the hypoinflammatory group. Even in the case of pediatric ARDS, which you can see here, fortunately, mortality is much lower, right? These are kids, but even so, that hyperinflammatory phenotype confers a poor prognosis. All right, but to be frank, there are lots of ways to predict bad outcomes in critically ill patients, so that's not particularly exciting. I think we're more interested in this really because of these differences in treatment response. So let me tell you a little bit about that. So the alveoli trial is one that Dr. Matthay did not mention, but was also an ARDS network clinical trial that compared a high PEEP to a low PEEP strategy. You've already been introduced by Michael to what PEEP is. This was a negative clinical trial with no difference in mortality. And we said, okay, well, we found these two phenotypes in this trial. Let's take advantage of the fact that there was randomization that was agnostic to phenotype and ask if there was any evidence that one phenotype or the other benefited. And what we found was what's called an interaction or effect modification, which means that the effect of the PEEP was different on the basis of phenotype. So if you were in that hypoinflammatory phenotype here, you did better with the low PEEP strategy, and the opposite in the hyperinflammatory phenotype. Okay, so that was kind of interesting. Let's go on to another study. You already heard about the FACT trial from Dr. Matthay. That was the trial that showed that a fluid conservative strategy improved ventilator-free days, but did not affect mortality, right? So we asked a similar question. Was there any difference in the effect of fluid therapy on the basis of phenotype? And once again, we found a significant interaction. So if you were in that hypoinflammatory group, you did better with the fluid conservative strategy. If you were in the hyperinflammatory group, it was actually the opposite pattern. So now we thought, okay, well, maybe these are just sicker patients, right? Like maybe the sicker patients are doing, better with a different strategy. So we tested for interaction or effect modification with the Apache score, which is a commonly used metric of severity of illness in critically ill patients, and we didn't find any. So we thought, okay, maybe it's something more interesting or complicated than that. All right, now what about pharmacotherapy, all those pharmacotherapy trials that I showed you? So we worked with a friend and colleague, Danny McCauley from the UK, who had conducted the HARP2 trial, which was a randomized controlled trial of simvastatin for ARDS in 540 patients. Now you might be thinking, simvastatin, that's weird, that's a cardiology drug. Has a lot of anti-inflammatory effects, great preclinical data, really compelling early phase clinical trial data, all right? And that was the justification for this study. It was yet another negative trial. Unfortunately, in ARDS, there was no difference in ventilator-free days or mortality. This is the original survival curves from the New England Journal, where you can see maybe simvastatin was nosing out placebo, but not statistically significant. So we said, okay, well, what happens if we stratify this by phenotype? And here's what we found. So the hypoinflammatory phenotype is here in the blue. So if you were in the hypoinflammatory phenotype, it really didn't matter if you got randomized to placebo or simvastatin, all right? Your mortality was about the same. But if you were in this hyperinflammatory phenotype, you actually had a significant survival benefit when randomized to simvastatin. Now, this is a secondary analysis. This should not be used to treat any patients and needs prospective validation, but it started to give us this sense, okay, maybe there's a treatment responsive subset actually that's been hiding within this broader group of patients. All right, now recognizing these blurry syndromic definitions within critical illness, we said, well, are these really phenotypes of ARDS? Or are they phenotypes of critical illness more broadly? And so we asked if we could find these phenotypes in sepsis. So in two observational cohorts, one from Vanderbilt and one from here at UCSF, the early cohort, we applied latent class analysis again. And even after we excluded the patients that also had ARDS, right, because they're overlapping, even after we excluded those patients who had ARDS, we still find these two phenotypes in patients with sepsis, and we still see pretty remarkable mortality differences. We were also really interested to see that in the setting of septic shock, we also see evidence of differential response to treatment. So I don't know how many people remember activated protein C. I know Joanne does, you're nodding. I see Michelle, right? Those of us who have more gray hair remember activated protein C, which was used in the early 2000s as a treatment for septic shock because of the Prowess study, which had seemed to suggest that it was beneficial, right? And we were using it pretty commonly. And then the Prowess shock study came out, which was a larger trial and a negative trial, and led to the drug being taken off the market, and Eli Lilly put it on a back shelf somewhere, and who knows where it is now. So we got access to the data from the Prowess shock trial and said, okay, well, is there any evidence that these phenotypes might have actually responded differently in that trial? And here's what we found. So again, hypoinflammatory is in blue and hyperinflammatory is in orange. And so you can see here that if you were in the hypoinflammatory group and you got activated protein C, and by the way, this is survival on the y-axis, your survival was worse. And if you were in the hyperinflammatory group and you got activated protein C, your survival was better. And once again, this was statistically significant. So again, we're starting to see this evidence that maybe there's been this treatment responsive subset that's been hiding in this heterogeneous group of patients. And maybe even that the hyperinflammatory phenotype could be what we call a treatable trait. Now, what does that mean? That means a biologic or clinico-biologic phenotype that is present across multiple different syndromic categories. Think of in the field of oncology, for example, a particular mutation that may indicate a certain mechanism, right? Our current paradigm we've been talking about, we talk about patients as respiratory failure, ARDS, and sepsis. And I think there may be lots of good settings when we continue to do that, but maybe for drug trials of certain drugs, we need to start thinking about other paradigms where we're characterizing our patients more on the basis of the biology. All right, so with that in mind, what are the key biological differences between these phenotypes? Now, we've spent years actually working on this, and I'm not going to be able to cover all of it in the time that we have left, but I just want to show you a few snapshots of the work that we've been doing, both on the host side, focused on the transcriptome and the metabolome, as well as on the pathogen side, because while we're talking about ARDS today and not sepsis, of course, the vast majority of ARDS occurs in the setting of infection, over 80%. And so the pathogen is a really critical part of this. And so with that in mind, I'm going to start with some work on blood metagenomics that's been led by Lucille Nathan, who's a wonderful informatician in our group, and Chaz Langelier, who's a fantastic collaborator and professor in infectious disease here. Now, if you're not familiar with metagenomics, and I think probably most of you are because we have it as a clinical assay here, but really this is a test that takes advantage of humans and microbes' shared dependence on common code of nucleic acids and says, well, if I take a biological sample, I extract the RNA or DNA and I sequence it, and then I can use informatics to deconvolute that into pathogen or microbe-related genes, which can be used in this case for pathogen detection, and then host-related genes, which I'm going to show you can be used for differential gene expression. So we started with the question of what differences are there in the host biology on the basis of the transcriptome in 189 patients with sepsis plus minus ARDS enrolled in one of our UCSF early cohorts, and it just very simply applied RNA sequencing to whole blood and found that almost a third of genes were differentially expressed between the phenotypes. That's a lot of genes, a big proportion, and indicated that there's meaningful biologic heterogeneity that really goes beyond just this protein biomarker level that we've been using to identify the phenotypes. When we asked what pathways really characterized these phenotypes, we found that the hyperinflammatory group is characterized by genes related to oxidative phosphorylation. Keep that in your mind. Innate immune response, glycolysis, keep that one in your mind too, and cholesterol metabolism. In contrast, the hypoinflammatory was characterized by a relatively more exuberant adaptive immune response. Now, what about the microbe side of this? So working with Chaz, we asked, what can we learn from the pathogen data that's in the blood? And the first observation we made was that there was actually a higher proportion of sequencing reads that map to the sepsis-causing pathogens in the hyperinflammatory phenotype. Now, how do we interpret this? Well, one interpretation would be that the burden of the infectious organism or the pathogen that's causing the syndrome is actually higher in those hyperinflammatory patients. We also found that the proportion of total reads that map to the Enterobacteriaceae family was much higher in the hyperinflammatory phenotype. And for those gray-haired folks like myself in the audience, that brings back the sort of gut ischemia reperfusion theory of sepsis that really, was popular in the 80s, right? That part of the problem in septic shock and in multi-system organ failure is that the gut is hypoperfused. You have translocation of bowel organisms into the circulation. Now, this certainly does not prove that, but if you're an enthusiast of that hypothesis, this might support your feeling. And this was also consistent with the clinical data we had, both from our UCSF early cohort and from a cohort at Vanderbilt, that clinical bacteremia is much more common in hyperinflammatory patients with sepsis. So clearly, we learn from this that there are differences in the host response that go beyond the protein biomarker level, and that the pathogen is at least part of the story in the difference between these phenotypes. All right, next I want to go down a couple of levels to the metabolome, and this is work that's been led by Nargis Alapana-Lechner, who's a brilliant physician scientist here on our faculty in pulmonary, and Angela Rogers at UCSF. And Nargis asked a very simple question here to start off with, which is in 93 patients, again from this early cohort, using plasma from admission, can we identify differences in the metabolome on the basis of the phenotype, controlling for a variety of different covariates, including liver and kidney disease and commonly administered medications that might affect these findings? And in fact, Nargis found a pretty vast difference. So even in adjusted analysis, almost a tenth of the metabolites were different between the two phenotypes. This heat map here has patients in columns and metabolites in rows, and the hypoinflammatory folks are here. And I certainly don't expect you to read all of these, but just to get the sense that there's actually a lot of metabolites that are much higher in the hypoinflammatory phenotype, which was kind of interesting to us. This shows the same data just displayed in a volcano plot. And you can see here that that hypoinflammatory phenotype actually has higher levels of circulating lipids, which was quite interesting to us. And remember on that transcriptomic diagram, right, cholesterol metabolism was one of the pathways that was really elevated in the hyperinflammatory phenotype. The hyperinflammatory phenotype, in contrast, was characterized by higher levels of metabolites related to glycolysis. Okay, remember that also popped up in the transcriptional profiling. and N-acetylputrescine, which has been linked in a recent interesting Cell paper to being a metabolite that's actually bacterially derived from gram-negative organisms. So this may be a bacterial metabolite that we're actually seeing in the circulation. So this led us to the hypothesis, which we have yet to prove, that the hyperinflammatory phenotype may be experiencing a glycolytic shift associated with mitochondrial dysfunction, in which, because of mitochondrial dysfunction, acetyl-CoA can't enter into the TCA cycle, decreasing lipid synthesis and shunting metabolism towards glycolysis. All right, so to summarize what I've shown you here about the proposed pathogenesis on the protein biomarker level, we have evidence that the hyperinflammatory phenotype has elevated inflammatory cytokines, endothelial injury, and coagulopathy. Now, I want to emphasize this hypoinflammatory group is still quite inflamed compared to all of us in this room, all right? It's just relatively lower than the hyperinflammatory group. On the microbiologic level, we see a higher pathogen burden and gram-negative bacteria as being dominant in that hyperinflammatory phenotype, as opposed to more diverse pathogens in the hypoinflammatory phenotype. On the immunologic level, we see innate immune activation and relative adaptive immunosuppression in that hyperinflammatory phenotype. And then on the metabolic level, we have this increase in glycolysis metabolites and a drop in circulating lipids suggestive of mitochondrial dysfunction. All right, so that is like very complicated, right? And that's just a tip of the iceberg. So how are we possibly going to translate any of this into clinical trials? And so in the last few minutes, I'm just going to talk about future directions in critical illness phenotyping and how we're incorporating this work into clinical trials moving forward. So I really want to emphasize that prospective confirmation is vital. Everything I've shown you related to molecular phenotyping is retrospective, right? Which is fine. And it's not that it's not useful and informative, but biology is really complicated. And our hypotheses about what treatment is the best match for what phenotype might be quite wrong. So we really need prospective confirmation in order to change our therapies. And that means phenotype targeted randomized controlled trials. But think about those patients that Dr. Matthay showed you earlier. Which one of these patients is hyperinflammatory? I certainly can't tell from their case history, right? We've been working to develop parsimonious real-time approaches to identify these phenotypes. And this is work led by Pratik Sinha when he was a postdoc here. He's now at WashU, in which he developed parsimonious models that are highly accurate in classifying the phenotypes. I'm showing you the optimal model here with IL-8 bicarbonate and protein C, which had an area under the curve of 0.94 in the validation cohort. But there are several other models with pretty good performance, including one that measures IL-6, TNFR1, and bicarbonate. Now, you're probably thinking, okay, cool, Carolyn, but I can't measure any of that in my ICU, so how does that help me at all? Well, it turns out real-time biomarker measurement is actually increasingly feasible. These are two devices, one but made by a company called Randox, and one is the Ella instrument made by Bio-Techne that can take patient plasma and give you a result for these biomarkers in a real-time context. And we're talking about within 2 to 3 hours. So this type of approach is actually relatively feasible. And I'm going to show you a little bit of unpublished data that's under review right now from my colleague, again, Danny McCauley, and his postdoc, Karen Reddy, who have actually tested this prospectively. So in the FIND study in 20 sites in the UK and Ireland, they set out to determine clinical outcomes in patients with ARDS or acute hypoxemic respiratory failure based on prospectively allocated phenotypes using a parsimonious model that we developed, informed by a point of care assay. I'm not going to take you through this whole diagram except to say that 663 patients were enrolled, including 525 with ARDS. And the key number here is that in 4.2% of patients, they were unable to determine the subphenotype due to technical issues or some kind of problem with the assay. But in the other 96%, they were able to allocate the phenotype in real time. And what did they find in terms of the outcomes? Well, this shows 60-day mortality with hyperinflammatory in red, and you can see that the mortality in that group determined prospectively was significantly higher than hypoinflammatory, and the same when we take a survival curve analysis. Okay, so then prospective phenotype identification is feasible. These phenotypes identified prospectively appear to have prognostic value. Are we ready to move to a clinical trial? And we think the answer is yes. So The Panther trial is launching actually in the UK this fall, led by Dr. Macaulay. This will be an international phase 2 clinical trial with real-time biological phenotyping. It is an adaptive platform trial, and I'll show you a little more about what that means in a moment. It's funded by the NIHR in the UK, and we've just been awarded DoD funding for here in the US. And so we hope to start enrollment at UCSF next summer, with funding pending in several other sites around the world. The population will be adults with ARDS with hyper or hypoinflammatory phenotypes. The initial interventions will be simvastatin or baricitinib, and I'm happy to talk more about that in the questions if people are interested. The comparator is usual care, and the outcome is 28-day organ support-free days. This is a schematic of how the trial will be designed. If you start with me on the left with adults with ARDS, those real-time assays will be conducted, and patients will be stratified into hyper versus hypo, and we anticipate about 30% hyper and about 70% hypo. Both groups will be randomized, okay, because we have equipoise about what's actually going to be the best treatment for each patient. And then there will be an adaptive analysis within phenotype. This uses a Bayesian design so that we can stop when a drug is either efficacious or futile. And because of the platform design, we can actually drop new drugs in then to test once a drug leaves the study. All right, so we're coming to the end here. This is a figure from a Nature Medicine consensus review published a couple of years ago entitled Redefining Critical Illness that posited that we are on the cusp of the precision era in critical care, where we move from the syndromic definitions we've had for decades to an era in which we're classifying patients based on underlying biology. And I think we're getting close, but it's quite complicated. As we dig deeper into the biology and the physiology and the clinical phenotype, we're going to uncover a lot more complexity. I don't want to imply that the way that I've presented here, that we've presented, is necessarily the best or the only way to phenotype these patients. I think really what we're looking for, again, is these treatable traits and ways to improve the actual care of our patients. With that in mind, the NIH is funding the ARDS Pneumonia and Sepsis Consortium. This is funded by NHLBI and NIGMS, a 4,000 patient observational study with rich clinical phenotyping and an expansive biobank. We are the lead site for the California Center. And samples and data are going to be widely shared from this. So if you have an interest in phenotyping, you can apply to get samples and data at the website here to try to answer some of the many ongoing questions about how to best biologically phenotype our patients. All right, so in conclusion, as the definition of ARDS has evolved to include high flow nasal oxygen and resource limited settings, among others, the core principles of evidence-based management remain consistent. And that's really lung protective ventilation, a fluid conservative strategy, and proning. We've identified these two latent phenotypes within ARDS and sepsis in more than 12,000 patients with differential responses to a number of different therapies, including pharmacotherapy. The driving mechanistic differences between these phenotypes are beginning to become evident, but we have to really stay humble about the biologic complexity we're facing, and that's why we're moving forward with this adaptive trial approach and with the APS consortium that can allow us to go deeper and to really learn as we go which treatments are the best fit for each phenotype. All right, I just really want to recognize that all the work that we presented here today is the work of a huge team, many of whom are in the audience, and just really want to highlight both our clinical research investigators, our data coordinators, our lab managers, all the junior faculty and postdocs. This slide highlights some of the folks who contributed to the work on the slides with the investigators in red, but also really want to call out all of our CRCs, including a UCSF medical student who's a former CRC who's here with us. They're the folks that really do all the hard work. So thanks so much and happy to answer questions.
Wonderful. Thank you so much for that tour de force, and you presented some really compelling and fascinating data. We have a packed house for people who are online and can't see it, so I want to make sure we leave most of the time for questions from the audience, but just had one question for whoever wants to field it, kind of related to the next-gen sequencing that we use, as you're obviously aware, very often in terms of infectious diagnostics, and sort of how far are we from using that for the sort of sepsis-related reasons that you delineated?
Well, that's a good question. And really the best person to answer that would be Chaz Langelier, because he's the mastermind of all of the NGS work that I presented to you. I mean, as you know, we now have it as a clinical assay right here at UCSF for CSF and for blood, right? So I think it's coming into use. Chaz has also been really interested in advancing its use in respiratory samples and nasal swabs. And so those are obviously somewhat more complex spaces because of the microbiome that already exists in those contexts. But I do think, I mean, we've already seen in the past 5 years how much more this is being used in clinical work. Chaz actually led a fantastic paper published in Nature Microbiology a couple of years ago that showed that host microbe metagenomic sequencing can really improve detection of sepsis and enhance identification of sepsis pathogens. So I think we're just going to keep seeing more and more of it.
Yeah, and just last week when I was on the ICU, we had a patient with cryptic respiratory failure and metagenomics identified pneumocystis.
Thank you. Open it up here in person. What questions are there? Just say your name first.
Brian Schwartz in the ID division here. Thank you. Great talk. Curious of like how the COVID pandemic and all the studies that were happening then and things like steroids, I didn't hear you talk much about, and how it influences the way you are the results from the COVID trials influences your thought about ARDS. And I don't know if you want to comment on that at all.
Start.
Well, I think as Carolyn indicated with the asterisk, we really don't know enough about how steroids work and which patients might benefit. Obviously, there was the benefit in COVID-19, but in a study that Carolyn did with a group at Columbia, it looked like the group in COVID-19 that were benefiting most was the group that had a hyperinflammatory a different pattern. So we're all aware of the community-acquired pneumonia study from France, the CAP-COD study that seemed to show benefit in patients treated with steroids, but then others are not consistent. So we're starting several new studies. There are ones in the UK. There's one we're going to participate in here called STRIVE, funded by NIAID, which will tackle respiratory infections in mild all the way up to severe, trying to apply metagenomics as well as clinical outcomes. So Brian, I think much to learn. What else would you say, Carol?
Yeah, I would say I think the jury's still really out on corticosteroids. There are 2 large clinical trials being done now in ARDS per se, one in Canada, the CORT-E2 trial, and one in the UK called the GUARDS trial. Both of those are going to incorporate some component of biological sampling so that we can try to learn more about whether there are specific biologic subsets of patients that may benefit more or less. I will say that our decision to use baricitinib in the Panther trial was informed in part by the results from COVID, because actually, although early in COVID, there seems to be a few more hyperinflammatory patients, the vast majority of COVID patients, when we phenotyped them, were hypoinflammatory. And so that's the majority of our patients, right? It's 70% of the patients. It's only a third that are this hyperinflammatory group that seems to be really responding to a lot of the therapies we've been studying for ARDS. And so part of the reason we chose baricitinib is that we thought, well, we'd like to have something that would have a hope of benefiting the hypoinflammatory folks, right? And we have equipoise, and maybe it'll actually benefit the hyper folks even more. So that definitely informed our decision, and we're going to have to think carefully about how steroids interact with both of those therapies in the trial.
Great. Let me take a peek at the time here. Time for one more question. Yeah. I saw a hand up over here.
Oh, from Dr. Sanchez, who's a wonderful member of our group, also recently joined.
Thank you for that wonderful presentation, Carolyn and Michael. I wonder if you could comment about the possibility of, or this idea of shared biology across syndromes that might at first seem quite different. So something that I'm thinking about is septic shock versus cardiogenic shock. And if you look through the lens of a complex kind of multivariable solution, because it's really not just inflammation, it's thrombosis, it's vascular biology. might you find therapies that may be applicable across different syndromes, and you find sort of endotypes instead of thinking about disease processes as something affecting the heart and affecting something else?
Yeah, absolutely. I mean, I think that's the whole fantasy, right, with a treatable trait, is that if we could find the treatable trait and identify it in multiple syndromes and then figure out how to treat it in one syndrome, it might work well to treat it similarly in the other syndromes. Now, of course, it'll be complicated, right? Because the cardiogenic shock patients, will have different side effect profiles maybe, or we can think of a number of different reasons that it might get complicated. But yeah, I mean, that's the fantasy, right? We're jealous of the oncologists. The oncologists have made so much progress in defining their patients based on their biologic markers and their biological phenotype. And we're really behind in critical care. But I think that is the sort of aspirational goal.
Great. Well, thank you so much to our speakers, and we'll see you next week.